we pray, Lord, that we possible to work together for the successful run of this innovation. In Jesus' name.
Amen. Thank you, sir. Thank you so much, sir. I'd like to invite Dr. Ogutoye, the Director of Kwara State Primary Care and Development Agency, to help us introduce the activities we have in this today. You are welcome, sir.
Thank you very much. On behalf of the Executive Secretary, Professor Nusrat, I want to apologize for having this meeting to schedule. It is due to some other very important state assignments. The Ministry of Health, when I say Ministry of Health, including all the agencies under the Ministry of Health, were to present the GHIG project today. But the Ministry of other events like this road to the Ministry of Planning, requesting for a shift date. However, it was lately yesterday that we were communicated that defense must take place today, and if they are not there, that means we don't have any money to spend for the remaining part of the year. So that's the reason why we need to start with. And whether some of the other invitees are not yet there, some of them are still there. So having said that, let me especially recognize our Executive Secretary and Chief Executive Officer of the Primary Care Development Agency, Professor Nusrat. Management directors, we have the state coordinators of WHO here, and other partners will also introduce very soon. And then also recognize the team lead from AHI, Dr. Timothy Ilorin. So my responsibility this morning is simple, is to introduce the dignitaries on their table. And let me start by introducing the state coordinator of WHO, the president of Dr. Emmanuel Itayo. Sitting next to Dr. Itayo is the UNICEF VSL in the state, Mr. Bolaji Abdulkadir. Sitting next to Mr. Bolaji is Mr. Ademola from GHIG8 Foundation. Next, sitting by the immediate right of the Secretary of WHO is the representative of the University of Teaching Hospital, Dr. Bilkis Muhammad. We also have the State Nutrition Officer, Dr. Olubega Wakoli. Next, we have Dr. Wakoli, the State Immunization Officer, Mrs. Venus Arts. Next, Mrs. Sarah, okay, behind her is the State Immunization Officer, Dr. Dupesh. We have our Chief Local Person, Dr. Adeniran Ayodij. Then we have the representative of the DPRS. DPRS is also another state assignment. And is represented by State MIA Officer, the person of this side and trade. So by my immediate left is the Director, Personnel, Finance and Supply of the agency, Mr. Lani Adidi. And by the extreme right there is the Director of Community Health Services, Elijah Hayat Ayodij. And finally, let me introduce our CEO, the person of Professor Nusrat Elelu. My name is Michael Ogutoye.
Thank you so much. Thank you so much, sir, for that introduction. I was going to tell everyone to do a self-introduction, but I think it's only what that is left to introduce ourselves. So I'll start with myself. I'm Esther Asori, the Technical Officer of the Digital Office Initiative. They're not clapping for me.
Good morning, everyone. My name is Rodney Mamadabra. I'm the head of department, Strategic Knowledge Management, GHIG8.
Good morning, everyone. My name is Abuola Daniel. I head the community programs for the organization. Thank you.
Good morning, everyone. My name is Ola. I am the program coordinator for this project.
Good morning, distinguished ladies and gentlemen. My name is Samuel Oluwaseun. I hold the commission of the Good morning, everyone. My name is Timothy.
I am Stephen Olubedi. Stephen Olubedi. I am the technical officer here for GHIG8.
Thank you so much, everyone. So to formally welcome us, please join me to invite Dr. Timothy Akimole to work for the welcome remarks.
Thank you. Well, once again, good morning, everybody. The Executive Secretary, Professor, good morning, Secretary, good morning, sir, the representative of all the other partners, Minister, Shigari, and I want to welcome everybody to this meeting. Just reflecting this morning on how the journey for this project started. I think it started around 2003. We were implementing another project in Osun State. One of about 60 PhDs in that state. We're trying to integrate pneumonia, diarrhea, and malaria management into the immunization process. The idea was that because immunization is already an established program, and a lot of women bring their children for immunization. So we felt we could integrate education about prevention and management of those three major diseases for the 5 children, pneumonia, diarrhea, and malaria, into the to challenge this with the organization program in Nigeria, miscloses, organization. And we told to ourselves, because we really think this should have been in India, that we can solve this problem by simply digitalizing the entire process. We looked at the process, we looked at the fact that when patients come, they have to run through registers to know their name, their community, to be able to identify them, team up. And they were not taking off no time, they were putting it in an exercise book and taking off later when the clinic was busy on the day or 2 days. So we knew that this was we all know there are a lot of inaccuracies in such system. So we decided that why don't we take a deeper dive into this entire process and see how we can, use technology to simplify it. I know a lot of people have thought about it, but we decided now as a team. And then, luckily, we have a very good relationship with the PhD board in Osun State too. Now, can you please organize your SIO and a couple of key immunization officers from the local government and from the PhDs? We want to have a meeting with them. We want to walk them through this manual process and let's even understand how it works. It was like a co-creation meeting with them. So we sat down together in the hotel, and all that. And then they walk us through the process. We're not, private organization, but we build up a public health organization, research and training. So after walking through the whole process, we now said, okay, we now went back to the office and started step by step. The first thing to do, let's pick the immunization register and just mirror it on the digital platform. Just mirror it, there's only immunization register. Look at the child health card, mirror it again. You understand? So that we're able to simply automate the entire process. And then we realized that there was this system where they were supposed to send in SMS to caregivers and influential community members. We said, look, this can be automated. We can put a system in place and we'll just send this SMS reminders of clinic visits to the caregivers, also the caregivers no longer is valid, and also to the community influencers. And we just put all of that and we brought our IT folks together we use consultant for this process. Understand? Our IT team work with the consultants to really, develop this robust solution. And when we were done, unfortunately the project was we're done with the project in Osun State, and then there was another opportunity to apply for another grant, and we said let's keep Kwara State because we worked with Kwara State before, and we went to a different state so that we can have experience of the state that's not really southwest. Let's do something that's supposed to be now, so that we can have a better view of what it's like in all those areas. So we did apply to implement the project in Kwara State and project safely. Before that was a good idea, and that's how we started. And to make it, which is why I need to really thank all the partners that are here. When we came to Ilorin for the first time, the first meeting we had, it was an eye-opener. There were a lot of things to assume based on all our things, and they just made us realize that we need to go back and bring people of tricks again, which we did, and it was very useful. So at that time, when we were able to implement the pilot, with a lot of input of all the experts in the room, and they were very, very helpful. FNX, Shigari, UNICEF, WHO, everybody came to the table and they were able to contribute. Even GSI was still in the country, in the state there. And it was very robust, but after the meeting, we were so excited because the reception was good. Everybody, felt it was a good idea, but they had a lot of tweaks. Initially we thought we could discard the paper-based complaint and use the electronic, and they were like, no, you can't do that. The national program of progressive paper, but we need to be side by side. So we have to go back to the drawing board and look at how can we make this happen. We need extra money, we look at the money, and make it happen. So we now have the healthcare workers focusing on the tablets, on the digital solution, while we employ some data associates to do the manual data entry. So that the data entry that's required for the national program is still done accurately and real time, while the healthcare workers, the organization officers are focused on perfecting the digitalization process using that tablet throughout, not worried about how to complete the manual form. I will start the result, and Mr. Iman will share on the success story, all of that when he makes his presentation. It's really exciting for us, and everywhere we talk about it, it makes a lot of people excited. We put a couple of reports out, and a lot of people reached out to us. Nigeria Health will reach out to us. Nigeria Health Watch is an online health newspaper. They reached out to us, and they came to Ilorin to do an investigative journalism. Instead of journalists from Abuja to Ilorin, he spoke with us. We went to the facilities, he spoke with some healthcare workers. He made us organize real patients, caregivers, and interview them. After that, he called themselves, you guys are doing a real job. Now I can say they did an article which was published on Nigeria Health Watch, and a lot of people are calling us from all over the world to see how they can be part of this. So what we've also done is I realize that just digitalization and automation is just the first step. Now we're going forward and we're bringing AI, and AI will just bring all kinds of algorithms. So what we're now is like primary school, you understand, just the basics of digitalization and sending automated reminders, which has no AI component. But now we've developed another AI component to it, and we some of the partners that are interested in work with us, we send a proposal so that we believe it will fly. So we plan to scale to more additional local governments in Kwara State and some other states. When Christmas program all of those on this one. So the AI components is a lot more robust. They have all kinds of algorithms built on it. It can do GIS, it can do your automated, mapping and micro planning for you. It will identify, it will predict communities. It's just based on algorithms on where you can be sure that there will either be organization or food investment because of the algorithm and every data that you put on it. And we now realize that we're also building a pretty solid database for 21,000 children. That is solid because that's what AI drives on. It's data. Everything about life is about data. Once you have data, but they say data is a new oil. You understand? Everybody knows that data is in and we can't do anything without data. So we continue to build on the database, we build it to have a more robust structure that the AI platform can sit on and begin to do all kinds of magic that will ensure that everything we're doing in terms of organization in Nigeria becomes fully driven by artificial intelligence, and it makes that easy for everybody. And that's where we have to be. So again, I want to thank everybody. everybody, and I want to welcome all of you to this meeting, and I want to have a fruitful deliberation. Thank you very much.
Thank you so much, sir, for that wonderful opening remark. So next on our agenda is group messages. We're calling on our partners. We have National Private State Development Agency, representative for the island. Okay, WHO. Thank you so very much.
Directors, what we have is what we want to appreciate the balance in governments, especially the balance in government and development agency for guiding innovation in immunization. Of course, also want to appreciate the guiding partners of this innovation assets. Digitalization is one of the major public intervention in primary care, and I'm happy that the state brought into this project session, and the stakeholders are carrying along. Some of us will have been more elaborate or expansive approach over the whole state, but yet we are happy that this will have guidance and we have the successful guidance. As for WHO, the government is ready to continue to support the Kwara State Project for all the intervention as improved the health status of the companies, especially for the each group as the children, ensuring that in our communities we reduce the spread of zero dose. In addition, agenda setting is strictly important that in Kwara State we have most of the children. Thank you.
Thank you so much, sir. Please, sir. You're welcome, sir. You're welcome.
Yes. All the directors, my fellow partners, and other SBC staff here present. I bring greetings from the minister, and first and foremost, I want to express my gratitude to GHIG8 for giving it fit to bring this pilot to Kwara. And at the same time, I want to congratulate you for the feat achieved so far. And we will be looking forward to scaling up, as rightly said, CEO. Thank you.
Thank you so much, sir. Affirmates. Okay.
Thank you very much. Yes, so we see that I'm not going to stand on substituting protocol. But I'm going to, first of all, thank Almighty Allah for keeping us all alive to witness this day. We are all here when we are here with WhatsApp, and we are here even to witness the close out ceremony. I want to congratulate the state. I remember when you came, I told you that when the state, this is a state with high achievers, and I'm sure the one you go with will be a success. So I want to congratulate you. I tell you, I'm looking forward to seeing the result of your work, because I'm sure you all know that the success of this project, it's a big win for all of us, because it will motivate our activities in the state. So I wish you well, and I look forward to the discussion. Thank you.
Thank you. so much, ma'am. Thank you, sir. You're welcome, sir.
Thank you for the opportunity. This will permit me to involve our distinguished EX and the directors from the primary health here. Honorable this afternoon, on behalf of GHIG8 Foundation, let me say we want to say congratulations to EHA for this wonderful job and for the long work that you have dreamt in the state. It's another opportunity to say I'm happy because this is synonymous to my name anymore. It actually shows that the state cannot work, cannot do it alone. The government cannot do it alone. You have come here and then you have made a contribution. I want to say on behalf of GHIG8 Foundation again that we wish you well, and then we'll be looking forward for this scaling up. Congratulations to Brazil.
Thank you so much for all the partners. Thank you for the wonderful messages. So next on our agenda is opening remarks. So now welcome with me, Professor Moses Ilorin, the Kwara State Government for the Executive Secretary for our opening remarks. So welcome.
Permit me to appreciate and recognize all the directors from the State Primary Health Development Agency. And also we have one of our heavyweights partners. I think we need to appreciate them for joining us. And all I can see, I think the representative, the state coordinators are working with us. Thank you so much for all of the research and information. Joining us in this morning. I also want to recognize the presence of the representative of the University of Nigeria Hospital. I want to also especially recognize all our partners, and of course my very distinguished program officers. I want to also thank you for the successes that we recorded in the country. Finally, I want to thank the EHI team, Dr. Team and his team. I want to really start my speech by appreciating Equitable Health Access Initiative for coming to Kwara. And when I saw them yesterday, I must also say a big thank you for accommodating my presence today. Because this meeting was supposed to be tomorrow, because I had another person engagement that is out of state. We were able to do this today. Thank you so much, everyone, for making that happen. I also want to convey the Honorable Commissioner's apologies because she's also out of state. She would have liked to be here. Unfortunately, the people that will represent her also at the budget defense. We are all discussing our budgets, supplementary budgets today, but rest assured that what we are doing here is for the good of the state, and of course, the state is going to be beneficial. So having said that, I want to reiterate what the team has said, that data is life. For those of us in the service delivery sector, especially the primary healthcare agency, if we've been tracking our progress in the last 5 years, we will understand that a lot of what we do in service delivery, we can only quantify what we do in terms of data. And when you see primary healthcare making the news, it is because I'm reporting our immunization coverage in terms of numbers, or reporting our stable attendance in terms of numbers, or reporting our zero dose tracking data, or so many other data on the file I'm trying to
importance of pillars to how much it is important that we streamline our data. And digitalization is one of the greatest ways that we can actually ensure that the quality, the promptness of our data is assured. So I want to really thank EHI for finding priority role of partnering for the automatic digitalized immunization system. I actually have a friend, Addis, so I hope I get that from Rory. So I hope that this will actually be a proof of concept that the states can scale in such a way that Kwara State can be a proof of concept for the country at large. We want to say that we look forward to all the feedback from the field. And indeed, I must say that there's ownership to this project, because when you came to the States a year ago, I think all of us in this room were in that meeting, where we made some real-time inputs to that system to improve it. And I'm really happy that a lot of all those inputs that we made was taken into consideration in the course of developing the system, and of course, piloting the system in the various local governments. This really matters to us because it shows ownership. It shows that you are actually strengthening the system. It means that you are also integrating with the existing system that you have met in the state. I've said that you work alongside the local government health authority with the program officers and the local government and of course at the state government level. It is good that we see that integration. Because integration is ownership, and ownership will actually lead to appreciable health outcomes at the state. So once again, I want to say a big thank you for finding Kwara worthy. Those things that makes a state stand out. When we won the state leadership, the North Central Award for the Leadership Challenge Funds, and I saw that Anambra won overall, and I looked at some of those things that stood Anambra out. One of it is doing things differently, and of course, digitalizing our process is something that can actually be what we can put out. Thank you for finding Kwara worthy. I'm going to be taking a lot of notes and I'm going to be listening with rapt attention to hear.
Reports, which will be presented by Mr. Abdullah. You're not the public audience.
Good afternoon, distinguished ladies and gentlemen. Standing on existing protocol, I'd like to present to us the results of what we've been able to achieve in the past 10 or so months working in Kwara State. May I speak myself? All right. So once again, my name is Onyema. I have to represent Equitable Health Access Initiative. So we're here to discuss the outcomes of this project. I was funded by the Pfizer-funded and it's the round 8 of the Global Health Innovation Grant. We also have immense support from the Kwara State Primary Healthcare Development Agency and all other partners who are working in the immunization space. Okay, so this is the title of our grant and insight. By May 2025, the grant is going to an end. So, Equitable Health Access Initiative is a dynamic, tech-driven, non-governmental organization. We leverage innovations to transform Nigeria's healthcare systems. And that was why the ABIS, the Automated Digitalized Immunization System is one of our flagship projects. We also have other projects in that line. We've been collaborating with the government of Nigeria since 2013 when we came fully on board, and we've been able to build high-performing sustainable health systems supporting up to 15 states. We've been in operation for about 12 years, and we have operations in the northern part of the country and the southern part of the country. Our focus as an organization is to use technology to drive transformative change in PHC and sustainable health finances for universal health coverage. So, looking at the immunization challenge, of course, all of us here will be working in the immunization space. We are fully aware that the WHO 2021 and 2022 reports give a very, very gloomy report about our performance. 2021 was 12.2%. Out of 18 million individuals globally, Nigeria had 2.2 million. Looking at that data is very scary. In 2022, we said it was even worse, it went up to 16%. So we had problems with manual record keeping, we had problems with logistical inefficiencies, and caregiver follow-up has been extremely inefficient. Next slide, please. All right, so when we sat, like my CEO gave the welcome introduction, we thought about the best way to contribute in improving the system. So we set out the goal that we're going to significantly reduce it, and then under immunization through digitalized registration, tracking awareness and education, targeting on the files, targeting caregivers, fathers, healthcare workers, community volunteers. And then we decided, since it's going to be a pilot, to focus on one local government, at least have a representation in each of the wards. And so we picked out one primary healthcare center in each of those wards in the Ilorin East local government. After, of course, having what they call it, a sit down with the state, and then the state was able to guide us in making that decision. All right, so we set out with the following objectives, and one critical objective is number one, to ensure that once we digitize the immunization register, we're able to ensure that vaccines can be tracked, tracking is more efficient, and then data management is much more efficient. And then we went on to decide that we're also going to build the capacity of healthcare workers. We're going to ensure that their knowledge in providing healthcare is optimized. We plan that we're going to engage 24 community volunteers to actively track or immunize newborns and defaulters. We also said we're going to, with the help of God, achieve 95% of newborn of all pregnant women registered for ANC to ensure at least that they must start immunization. 95% of all children should also complete their immunization once they start, and then we also want to increase routine vaccine awareness and education at community level and conduct evaluation research at the end. By the grace of God, we were able to achieve all of these objectives. All right, so now I want to introduce the automated digitized immunization system to us again. You know, there was one of those wonderful meetings we attended with the state. And someone said, this is a wonderful presentation. We must go to the field and see whether it is true. And yes, we got the state to engage in the joint supportive supervision. It was a wonderful time, and some of the outcomes we will be sharing at this report too. So our aim, by the grace of God, creates a seamless information loop from data entry at the point of care to strategic decision making. From the caregiver, the healthcare worker at the facility, till it gets to the table of the ES, we've been able to digitize our system. Although, like we said, it's still at the pilot start, you must finish what you start. So you start something, you carry over to the next year, and then you need some other things like missing data. And then our system, we have built into our system automated SMS reminder, such that you get reminders first 72 hours before immunization, and then 24 hours before immunization. The idea is to make sure that we cut down forgetfulness. Now, we have 3 tiers. We send to the healthcare worker, we send to the community volunteer, we send to the caregiver, mothers, fathers, so that, for example, the community volunteer has the responsibility of ensuring that everyone in the line list must be contacted via phone. So we have SMS 72 hours, SMS 24 hours, a phone call 24 hours. Then we also built into it an AS immunization integration. Now, this is particularly innovative because we determine that every facility where we're going to roll out ADIS, we don't want institutional right clinics operate separately. We only assume that once the pregnant women deliver, they should know that they're supposed to bring their baby for immunization. No, we don't take that assumption. We make sure that we lie to the ASC clinic. We go as far as when the gestational age of the pregnancy, determine the EDD, and then, in fact, in my presentation, I'm going to show you how the ADIS calculates the EDD once we get some basic information from the mothers. And so that has been done in this application. And then, of course, the dashboard is also automated. Like we said, everything is still undergoing further development. But you will see how far we've gone. Next slide, please. All right, so the EIR, the electronic immunization register itself, is digitized. Critical to this, one of the critical good part of it is to ensure that it eliminates transcription error. That means, for example, for some of us who have been in the health system for a very long time, we go for supportive supervision. You see, when you are looking at the register, we have a link. And some writings you can't see, a lot of missing data. So what this digitized system does for us is to ensure that no field is left unfilled. Did you get that right? Thank you very much. So it uses unique child identifiers to link mother and child, such that even if a mother has more than one child, and she's been able to register for ANC, the platform is able to register all her children under her. So it's not like they're going to be opening new fields. So it's pretty organized. All right? So, of course, we talked about the automated SMS and tracking system. Added to that, like I said earlier, it works with the fact that it generates automatic line lists. We will be demonstrating the app in this meeting, so you see some of these things, real as it is being carried out. So right now you have the interface of the app, because some of us who have interacted with it, and then that's an example of an SMS that was sent. Next slide. All right, great. Now this is just showing us some of the interfaces on our digital platform. Now the one on the extreme left is the major dashboard. As of this morning, data is still going because we have our people on the field using this application. This morning we have 21,143,000 children on our database, and the number is growing. We will be able to register, or rather, we have on our system 2,178 pregnant women who will deliver soon. Okay? Today, 525 entries have been made, and we are getting data from 13 facilities, 12 PHCs, and the University of Ilorin Hospital. Right? So, now here you see the delivery list. It actually goes as far as the names of the mothers and their EDD. Some mothers that by the grace of God going to be delivering tomorrow. You see, June 19. We have been, if you scroll up, you see June 20. Before the June 17. This system is able to help, such that once the mothers deliver, it's so efficient that even if, because we are in a traditional system, some of them may not even come to the facility to deliver. We already have the data. We are able to track them to their houses. Now, we make it so flexible that 1-2 weeks after delivery,
course, not all these things are calculated. It could be 1 week before, 1 week, 1 week after. Someone checks on them because we call. How are you? Have you delivered? Yes, I'm good to bed. Okay, would you be coming to the hospital for immunization? Whatever happens, the community project is able to follow up. This system has capacity to get that done. Next slide, please. Alright, so it's a mobile app with several functionalities like we just described. We're hoping to move to the offline capability as part of the upscaling we're talking about. There's a whole lot we're going to be talking about when we get to future roadmaps and then next steps. Okay, so we're hoping that we're going to be able to do the offline capabilities so that all our healthcare workers, even when there's no network, you'll be able to still enter records. So that when you get to a place where there is network, the system sits. Alright, target is to make sure that we are tracking zero rows. You see that picture? It was this project that encouraged me. In fact, the love for this project. We went to places that I give kudos to all of these classes. I really appreciate. I walked to Kwara State. We walked to Kwara State how many years ago? So the last time, that was how I got to meet some of the great people I'm working with today. As far back as 2012, yeah, 2012. I didn't think that these places will still exist. This is 2025. But one of the beauty of this is that it reaches everybody. In fact, interestingly, when we began to push our PhDs to intentionally go out for outreaches, within 3, 4, 5 months of intensive outreach in these areas, we were able to identify 200 children who were already zero, as in zero rows. They were born, nothing was happening in their life. Okay? Next slide, please. So, we want to now discuss some of the things we've been able to achieve in the past 10 months. We were able to engage all stakeholders early enough, and we are so thankful to all of you. You know, this is a good place to put your hands together for yourselves, please. Thank you for support, thank you for cooperation, thank you for your advice. And of course, we now went on beyond the general state where we have every other person. We had a core group of technical people, the state program review team, and we were having meetings. We were able to have JSS leaders, the joint supportive supervision, and 2 higher volume, different facilities, priorities. Sino and UITH. Yeah. So, like we said, we saw on the dashboard, we were able to register more than 21,000 children. Of course, this is a free open source web mobile app that has the electronic immunization record and register embedded. We are operating in 1 local government, 12 PHCs of tertiary health facility, covering 183 communities. That's the catchment area of all of these facilities, and that is humongous. That's humongous. And like I said, we've been able to register more than 21,000 children. We've been able to achieve completeness of immunization data, like I said earlier. The app does not allow you to leave any space and field. Oh, when you go to, of course, I know I'm talking to experts here, the registers will have missing data. But we made it in such a way that you cannot skip. You can't go to the next line without getting. That means it also helps the healthcare worker to probe further to get proper data and then enter. So it doesn't allow for missing data. It doesn't allow for someone to say, I don't know what they wrote here. So now we are going to be having challenges with transcription. Is it 5 they wrote, or is it 7, or is it 8? Now, we now also be able to achieve 50% improvement in timeliness of data entry. Interestingly, when you go to the field now, before they would have put the cards in the immunization register and packed aside. Some of them may be lethargic to enter the register. You have to open catchment area by catchment area by the time you put this song gets high. But once they handle the tablet, it's so easy because you have the name, you have the catchment area, you have some identifiers that makes data entry very, very easy. And so we've been able to achieve at least
50% time limits. It saves time, no need to postpone data entry. And then from observational study and interviews, it indicates that time to attend to caregivers and children, there's no more anything like time. They're able to save time, and everybody's able to get busy doing something else after. Now, so of course, added to that is the fact that the healthcare workers are very excited, particularly the RIs, when they have to enter the tab on the app. They are just very excited. Okay? So, we've also been able to achieve 50% increase in the accuracy of monthly report comparison in the Ilorin Institute. So it's easy for them to do aggregation. Aggregation is easier. There's no arithmetic error. You know, when they count off, I've done, because I'm in the M&E field basically. When you go for supporting supervision, you are conducting DQA and you see numbers that don't add. That has been taken care of. So less headache on the long run. Alright, next slide. So, beautiful. These are real life pictures of locations we've been to in the course of working these 10 months. That's somewhere in Agbiyogi, in Kwara, yes, in Kwara. Then somewhere in Liapa, interesting, beautiful places. Beautiful places. Okay, so we also achieved 6% reduction in missed appointments because we have a system that generates line lists. People are able to follow them up. There is no exit I didn't remember. In fact, it's so serious. Of course, the organization schedule is flexible. If you are not available today, the caregiver, the CE as community volunteer, they will ask you at the earliest opportunity, bring your child to the hospital for immunization. And then they will be able to do training. They will be able to also build rapport with most of these mothers. So it's easier for them to understand that when they are calling from the hospital, they are able to respond. Alright? And then, like I said earlier, I shared this fact that within that period, we'll be able to, in areas, pumping up areas, we'll be able to pick up 200 children who don't have any form of immunization inside. Going on with our achievements, tracking has also improved significantly. Going away from the tickler board system, where you will first of all have to remember that you have to go to that board and pick the card and then call. You have sent emails, you have sent SMSs. So, success rate in tracking has gone up. And then in terms of drop-off means it started and then you did not function. That has also been reduced. So you see people who start, someone is always calling them, reminding them. That number has significantly dropped. Alright, so what all of this has helped us to understand is that once we engage technology correctly, it actually gives us a lot of benefits. It amplifies reach, trust, and then we are able to ensure that no child is left behind. It's like this. Alright, over. Now, I've mentioned some of these things. One of the things I'd like to mention is the number of supportive supervisions we had. Because this was a pilot project, we ensured that we're physically on the field at least once every month. Every facility had visits from those in Lagos, and we had to, of course, we have in Lagos, having an Kwara office, we were always in touch. We were having meetings regularly. So brainstorming was like second nature to us. So we had a whooping 104 SSBs, and we are glad because every of those SSBs led to improvements on the habits. Now, these are some of the key principles. I've talked about them in passing. The allow for data accuracy. There is automated workflow. Like I said, once you pick up the tab, you pick up the child health card, you enter the data from start to finish. And it does. computer. She was so happy. I was like, wow, interesting. So it has allowed them to have some trust in the system. Next slide. All right, but however, we still have challenges, and we hope to overcome these challenges as we go on. Now, we have digital literacy gap. Some of our healthcare workers, of course, they were familiar with us. So, with trainings, the first training and the refresher training, we have been able to bridge that gap considerably. Okay? In fact, because at the end of the project, we had an end of project survey. Between when they started and by this time when we're rounding up, their knowledge and capacity to do a lot of things had increased, had improved. Okay, so we also had the problem of connectivity because we are still in Nigeria. We are hoping that some of these problems will be able to overcome. For example, for the internet services, we may not be able to do anything immediately, but about electricity, we can work with solar options and all of that. Okay. We have internet. Okay, I think I talked about that. Next slide, please. Okay. Now, one of the beautiful things that came out of our joint supportive supervision is this Excel sheet I want to briefly share. And I think Dr. Shitu, Dr. Lashikon, Dr. Itai will be able to relate, and I think Nicola will be able to also remember that one of the advices we got by going to do hands-on was the fact that we need to know the outcomes of all our babies once they start immunization. And UITH is a peculiar place. And knowing full well that when mothers come to that place, it's not like it's a primary healthcare center where they can consistently return for immunization. Some of the mothers are from many different places, and so they just deliver and then they go. So one of the things we discussed was how can we know if these children are continuing immunization? So as a result of that, we developed this tracking tool peculiar to UITH and any other facility that may be in that space, such that once they take their first vaccine, you will notice from here, you can see clearly, where we have tracking status, returned and was vaccinated, then transferred out. Then you have the column where it's showing final outcome and then health facility transferred to. Now, we are hoping to, in the next phase, build this into the acts. So right now we're still doing the manual collection because it's only one facility. For the IT team, this is on board already. When we go to scaling up, such that even if it's not just UITH, any other place where it ever happens, we are able to track our children to where they are born to continue immunization. All right, next slide. Now, while we were putting the ADIS together, we had one big problem. So we observe that the state does not have a uniform patient ID. And if you want to digitize the system, it's not going to be possible for you because you will have duplicates. Even though things are different. As long as you're going to enter number as an ID, you're going to have duplicates. You have Otakoro 001, you have Obisino 001, you have Agayaki 001, you have Adu 001. By the time you log into the system, it knocks them out. So we're going to be losing data. So one of the things we have decided to push to the state by way of suggestion is, can we look at the way of having a unique patient ID, being for the child or for their mother, depending, and then we're going to have state code, local government code, facility code, and then community code. Now, the reason why we included community code before we put patient code is so that we think, for example, Otakoro, for example, I don't know the names of the communities, we can separate whoever is coming from. Okay, let's not use Otakoro as a road. Let's use Ilorin East as local government. So within the Ilorin East, Obesino has catchment area. So we just mentioned, can someone give me a name? Okay, Southern candidate. All right, okay, Gambari. All right, so maybe we do GB for Gambari, so that the community, the person can still, like, I don't know, we'll have to do something critical about this, because once we are able to cross this model of identifier, our database, that was 1,000. We're not going to have, because now what we de-identified, such that our database is currently not picking hospital numbers or immunization numbers. They are just entering names, so we are still on board. But we are going to stage where we are going to de-identify. Names are not really necessary. You need to work with IDs. So it will be critical for the state to actually sit down and determine how this can work best for us. It will be easy because once you are going to be digitizing the system, you can pull up any information from anywhere. For example, our banks, our HMOs, you can stay in Ilorin and transact business in London because you have a unique identifier. You have a mobile number, you have a switchboard that identifies you clearly. So we can think of that for this. So what I just did, sample Kwara, Ilorin is Ojagoro 0000. We'll think about this is on the parking lot. Next slide. All right, so next steps. Like my CEO said, our heart desire is to scale up. We want to scale up, make our IDs more robust, more functional, and then move it into other local governments, into other states in the country. We want to include AI to make it more robust. It's going to be mobile, it's going to be integrated into GHIS. We also want to ensure that there is sustainable study that in terms of cost effectiveness, if I want to think of making it commercial, of course, innovation and the regulatory and stock management. In conclusion, we understand that technology bridges the gap in data logistics and product, and what ADIS has helped us to do is to automate our system in the area of immunization. So we are looking for a scalable model that will align with, for example, this year's immunization theme, that immunization for all is humanly possible. It is possible. Next slide. Please serenade yourself with some of the pictures from the project. Thank you very much.
Thank you so much, sir, for that wonderful presentation. Once again, let's give him another one. So I'm sure some of us might be wondering that this ADIS will be mentioned. How does it look like? So we're moving on to the next on our agenda. We are demonstrating how the automated digitalized immunization system works. So we'll have Mr. Tayo to present on that. Welcome, sir.
Good afternoon, everybody. Sorry, I'm not going to sing because I want to demonstrate magic. Okay, the ADIS is not is an Android tablet enabled, but I will be projecting through my computer. This is what we did was we don't want to make the application person specific. So what we did was we created an email for each of these facility, so that when the person in charge is leaving to another facility, you not say we are using an email, so it will be the email facility. So I will log in, typing in one person, two people does not have the same ID. So it will automatically bring that person, and within seconds, based on the internet, you have access to the information of this woman. So if I click this is the information, so you can edit the details that we just inputted in the create new, and this is the information. And if you go to the delivery, so it's talking about the date of delivery. This is important. Immediately this person delivers and he confirms. Some of them doesn't come in, will go back to where they did the ABSC. The person confirmed that I've delivered. You click on this confirm as delivered. So because sometimes there may be error, it asks you, are you really sure that this woman has delivered? And when you say yes, deliver, he told that icon which is green before to green, telling you that the woman has delivered. So the next, if you see the other body, the other body is in green, it will not turn to green until we confirm that woman has delivered. What we did was we linked the woman to the baby, because the objective for doing this is to bring the child to the facility for this or vaccine. So until this woman brings this child to the facility, it's all record that this ANC side is not completed. And that's why we said link with the immunization register. That grade return to grade immediately we confirm as delivered. So let's assume the woman has delivered and the child has taken the vaccine. That means he has a record in the immunization register. So they will click on the link to the immunization register, and it will tell them to search for the ID of the child in the immunization register. That means they are connecting this woman to the child in the immunization register. So this account will be sending notification until that woman brings his or her child, or brings her child to the immunization register, because this will not be closed. But immediately we are able to link this woman to the child, which has a record now in the immunization register. This account for this woman is closed, and the ANC register, the woman is done with the ANC register. So the next one is the immunization register, like the ANC register. A new child is brought to the facility. Like this is a mirror image of the manual register. So every information that the manual register that will collect from the manual register, that's what is here. So the card number, the birth card number, child name, and all the details, the parent and guardian, and if other this parent and guardian information there's an icon say add more. So you can add, because we discovered that the caregiver may not be the mother, may not be the father. So you can add this the caregiver's name, but if the caregiver is the mother, the only thing you don't need to enter the name again. You just click same as caregiver, and also the father's name, because sometimes we discover that from the field that some of these caregiver mother don't have maybe a phone number. They drop their husband's phone number, so we can track them through the phone number of their husband. Okay, the essential information and contact number. So the most critical thing in this form that we added based on the field experience is the existing users. How do we bring in those people? Because this is a digitalized system. I can write a date of last year today it is a manual register, but this digitalized system will be the date you enter that information. That's one of the strategy of not making the healthcare workers to postpone entry, because we are looking at real life information. So, but there are some people, there are some children that they have not taken any vaccine and they will live in the community. How do we enter their information? Someone that was born last 2 years, and if you enter the information, it will be today as his birthday, which will distort the schedule of the vaccine. So what we now did was, we now included this existing user field. So if you click here now, if the child is born today, it will say no, that means it is not an existing user. But if the child is maybe born even yesterday, he has gone to an existing user. So that we are telling the system that this child is not born today, so that it can give us, and like now, if a patient, if a child relocated from another facility or another state and has been taking each of our vaccines, for this they must document it, and this is the way to enter this information. So immediately I click this yes, it will bring all the vaccines. Let's assume this person has taken some of these vaccines before coming to this facility. Now they can manually, I call it manually because now they just be checking it. So if I check it now, it will ask me the date for me to select the date that this person took that vaccine, where he or she is coming from. So I can now pick the date. So it will not be the date of that date. I can select that date that the person collected this vaccine. But if this person has, maybe is somebody that has not taken any of this vaccine, we will just leave it empty. So, and if I'm giving this person maybe OPV 2, I'll just pick today and pick today's date, and I will submit it. So that gives us a leverage of bringing in children that have missed their doses, but they want to start based on their age. They want to start, and based on the window period now. So this is, and immediately we do continue. It will, the last vaccine, if I pick, for instance, if I pick rotatary now, this rotatary will now be what will make it to schedule the next appointment date for the patient, because now we now have the information of that child now. So it now automatically give the next scheduled date for the patient, for the child. So after entering this information, you can view the child through the existing user. Now we now have the information of the child with the existing user. So like we said, the IP, we don't need to be looking around for the name, just type in the IP in this search button, and it will bring us the child we are looking for, and we click on the child. So now we have the details of the child, immunization. So when we click on that button of immunization, we can see all the vaccines the child has taken. So that this child now was born on June 18. So he has taken his BCG, the three vaccines. So those vaccines in green, that means he has taken those vaccines. And the one which is green, that means he has not taken the vaccine, is in the future date. And the ones in black, the ones in black means the color coded black means he has missed that vaccine and he cannot take it anymore based on the window period. And there is another one red. He has missed the vaccine, but he can still take the vaccine based on the window period for the national immunization guide. Okay, so that is how the app. So also we have a web application that the super admin can check. So I will show this one down and able to show us the part of the presentation of that Mr. Lima did, he showed us some screenshots. This was when we got this screenshot. So this is for all the 13 facilities that we are using. So this is all the, so you can see now, total denies. When Mr. Lima presented in the morning, he said it's 21,114. Now,
143.
so now, based on the
work going on,
it has gone to 21,159. So this we can see.
even ANC2 has increased.
So ANC has increased. So the 13 facility, and these are the icons that we can see. You can see different icons: the registers, the record, the oncoming appointment, complete appointment, and missed appointment. So these are the things that these are real life that you can make decisions based on this dashboard. So like I said, this is generally for the 13, so we will not really but if you can see the different health centers are doing, and you can see, and you can see when they are due, they are still started, they are still they know. What happened was, because we imported some data when we started this project, some of those data we were not complete, but we cannot fix them. So the only thing we can do is tweak them. Some of them are still manageable, we're able to do them. But those ones that you see now, like I said, all of those things now they are required, we must include them.
No, but if you look at it, this is not repeating the health center different. If you look at it, Kamali Farid, that is missing Pentawa, Rota, Okimima, we know that it's happening. So all the way down. But I don't know why it's also still interspersed with Again. So I think there's a data cleanup issue there. So you can see the same person that is in Akwado and Again, except if they're registered in different places, because they're not so far from each other. You get it, the same person. Yeah, so it's not repeating the same, so I think it's a better.
So we look into that.
Yeah, I think it should.
So one of the things that
counts, not one person, it counts on
that's why we said these are not unique, they are repeated based on
based on the activities.
Because if you are trying to count them uniquely, it will distort how the application is counted. Because like now, Penta 1 will rely on Penta 2 rely on Penta 1, and sometimes although Penta 1 and maybe Penta 1 they are collected at the same time, sometimes they do not get the vaccine of Penta 1 will not be available, and if we say they must work together, that means immediately they collect Penta 1, they will not able to collect Penta 1 when it's available. So we make all those vaccines to stand alone, Penta 1 stand on the unit, and until they collect Penta 1, So that's why when you need the vaccines now, you will pick it one by one, so that we can know which of these vaccines were used. Okay, so one of the things we did was nobody can access there is data protection, because that's a major key about data now. Based on the permission, that's why like the scaling up that we are seeing that we talk about, now we partition this in different facilities. But for the upscale now, we are trying to create a system that just like we have a bowl that every facility is dropping their record inside. But the permission we are going to give you, you can only access your PAC based on the permission you have in the facility. So it's not that I'm working in Airbnb, I can access Apado, but if I'm the maybe local government immunization officer of Ilorin, I can access, because of my permission now, I can access everybody under me, but I cannot access for Elisha from Ilorin South, another local government, and the person will stay too. The state immunization officer can access every facility in the state.
Thank you for your presentation. So I'm sure we all noted a lot of things now. So we'll move on to the next on our agenda, discussion. Any feedback from the partners?
I know, for example, OPE0, you take that before you take OPE1, 2, and OPE3. But there's something unique about that. If you don't take OPE
the immunization system that's currently operating, that's what I'm saying. But what I'm trying to explain now is, because we have discovered that the ones, if you go to the facility, you are supposed to put them together. But we discovered that if we mark them together, that some of those facilities are not available. So if I come to the facility today and I take Penta 1 for instance, automatically it will schedule me to Penta 2. So maybe the following week now say I should come for Penta 2. So the Penta 1 that we use. So the second week I will take that Penta 1. And we now start counting for Penta 2 that second week. But if we do not unbundle them like that, that means because I've taken Penta 1, it will cancel. I've taken Penta 1, it will cancel Penta 1 the day I want to take the following week. So we now unbundle them, Penta pills, or their own Penta pill, and other ones to their own. But if they take them on the same day, that means we will share them two automatically. And like we said, if you miss it, there's a window period which the national guidelines say all of those things are there. Until you miss that window period before you cannot take any of those vaccines.
Thank you so much. My
only concern is about I think we should have a way to synchronize the data too. Because the paper-based we're using right now, if a child takes the first dose with the card in the morning, and take the second dose in the card right now, and you know it's paper-based, just take it and take it as supposed to be. But right now, you said something about someone taking the GHIG8. I don't think
No, I didn't say that.
so you said
no, that we just try.
they are about to do it. And
what we said was that we are able to follow up the child because they don't continue to receive immunization at GHIG8. So they go somewhere else to continue. Yeah, but we want to now know from our tracking where they have gone to pick up immunization going forward.
All I'm just saying is the data should sync just one server. If you take it, present your unique ID everywhere else, you can just that's what we're saying.
So just to add, I think we should mention this. We are trying to work with the national so that before I understand what he's saying now, before we can do that, that means all the facilities in Nigeria will be on board. So if I take, and that's the first thing that we must do is having a unique identifier. So if I go to like before you open an account in any branch, is that branch that you can withdraw, you cannot go to anywhere. But because now is unique identifier, I can open Ilorin and I can pick out get my money in us. So until all of these PACs are on board, and like we said, this is pilot stage, and the 13 facility now that we are using, when we on board, like we said, we partition them, we can just really access, but for the upscaling now, all the 13 facility, so far you have this unique identifier, you start your fasting with the first set, maybe in UIT. When you get to Ogeshi or Ogeshi, just present your unique ID. You don't need to get registered PPP. You just type in your unique ID. It will pick it out and you can continue from there.
So from your presentation on the diagnostic, from ESC, common facility. So I see the name of the child is same. There's co-attitude, which is like mental one, is one. But coming to the facility, the date, the phone number, the time, and the day is also the same thing. But coming to the facility level, we see again and with that time frame, a child cannot live again into a Apado within that as if we know that there's sometimes that the accident may not be available, you can directly go to another facility to make it. But we're looking at the database, they're having the same day, the same time, so, and the facility name is different. So that shows that there's still not a neatness in that. Because I can decide to pull out the data of the child in social facility or social contagion that to know that is to be able to handle vaccine usage in that facility.
So I think from that data was like our staff I think the name is the same, but it's not the same because you cannot PAC. So that means the names are the same, but it's not the same. The same. So the names are
I think it's a data entry, maybe the important data.
yes. So I think
just have a look at the
yes, we will
check it.
Thank you very much. 10 million you have 50%, and since you said that data entry is not postponed and in real time, so why are we having a 6% to 50% and not 100%?
It's improvement. It's percentage improvement.
So that's the baseline.
Percentage.
So I think it goes back from baseline to where we are now. So let's baseline for what?
Yes.
Not for every, not for this project and the process, yeah.
Thank you, ma'am.
Thank you very much for the presentation. So I think that for this study, you would have also encountered some limitations.
Yes.
But I think I want to ask, was the ad is able to pick out the clients that were lost to follow up? In as much as you are tracking, it's inevitable you still miss out some people. Do we have the numbers?
We have the numbers. We have the numbers.
Okay.
We have the
So
numbers.
because I think that should be a limitation that should be projected in this agenda so that we can work on that.
We have the different outcomes. There's a dashboard that shows the various outcomes, transferred out, lost to follow up, dead, returned, all of those. So I want if you can project what we have it, yes.
So after now, will Ilorin East also continue with the electronic data entry system?
Yes, they are. They are. As we speak, they are still continuing. We have Pfizer-funded was gracious to give us 4 months extension, but we hope to, within this period, my CEO mentioned it earlier, once we are able to get some support, we want to rejig the system, make it stronger, and then expand. That's our plan. That's our plan.
Thank you.
Thank you.
And something I think innovative to this, not for organization now.
Okay.
Since you follow up or you register women from pregnancy, from antenatal pregnancy to delivery, and then to the point of these children, where can we now have linked it with better registration or looking into the future by working with birth population since it's automated? That way you're able to capture all the data and then something innovative from what you have done. Thank you.
That can be done, but because we started from there, we can always expand. So this is where we can have in April, when I checked this dashboard, vaccinated numbers were at 800 and something. So now we have over 1,000. So the numbers keep automatically updating. So we have it. Vaccinated, improvement schedule, transferred out, schedule, just follow, migrated, disease. We have the outcomes. So we want to, because this is also tied to that, and this is the back end, then we're able to put up this report.
And I see you have only 5 people lost to follow up. It's just trying to let us know how far or how much people are there to their visit.
So we still, that's why we said 38% improvement. So there's still that data reporting challenge, nonetheless, but we are going to get there.
Just to add, now what we discovered, this is not automated, not from artists. After during our meetings, different meetings, and we came up with this. It was not part of the what the initial stuff. So it was the community volunteers that are updating this. So there is errors, possible errors, many things. So now, like for those getting now, the AI that we are introducing, we capture all these things. And the one we are saying, talking about, when we keep having this data, that's the algorithm or the AI, we predict all those things based on the data. So far we have the clean data. That's why we are upscaling with AI. And those are the advantage that they, those things, be able to provide for us, even for the life of time.
This one is like an advice. I know that sometimes ago, 2 years ago, God this was in June when we started working about the social just a bit. But currently, I don't know if you started exploring this idea of distribution because this not only way to define organization, lot of other interventions in government, secondary and tertiary. And I know there is SOMAS and there is DHIS. Currently at the national level, they are trying to match the two SOMAS and DHIS. However, SOMAS has a component for electronic registration, which we have not started using all in the country. So, again, it would be a good idea if we start thinking how this particular app can be integrated and made into that platform. That's so much interest in platform. It's possible that you have already done that, but I'm just thinking.
Thank you so much, sir.
Thank you so much, sir. A lot of applause. Any other feedback?
Yes, I have to.
Applaud. Any other feedback? From any partner? No, thank you.
Thank you so much. I think I need to commend the EI team for that detailed presentation. And of course, also commend all our partners and friends and colleagues that have also made a contribution on how best to improve the process. We know that this is work in progress, and we have to emphasize how best to improve this system. And I think the last advice from the state coordinator World Health Organization also worked with the team. If there's going to be a national data platform, there has to be some thoughts about integration. Having said that, I have a few comments of mine. The first one I want to talk about is the unique patient ID. I think this is a very important proposal. And I want to ask a question. I know the DHIS too, I don't know if our health facilities have unique IDs. If the M&E can help us. If on the DHIS too, we have 503 facilities offering the immunization. We have facilities having their own unique ID. If we have anything like that, I think that would help to automate this patient's ID. So let's start from there. If there is facility ID, we can integrate it to state LGA and then that facility ID. It will be unique so that even if we are integrating onto the DHIS too, it's also different from what we have. And then can it also be automatic? The patient ID, can it be automatically generated by the app?
Yes.
Because if you ask my health workers to begin to enter number 1, number 20, I'm sure you're going to have several authorities. So those are my thoughts as regards the unique ID. I also wanted to comment on the expected date of birth. I think this is a bit of a misnomer. If you ask people the expected date of birth, I'm going to put my date of birth. If you ask the expected date of delivery, this use of language. So if you ask people when is the expected date of birth, they will forget the expected and give you their date of birth. So I think it helps to have an EDD where everybody knows EDD is EDD. So I think that would help us to be seamless. The third thing I also wanted to talk about is around vitamin A and HPV vaccines. We know that the vitamin A will end at 5 years, 59 months. I think Dr. Bankole is not here. And we also know that HPV will start at 9 years and then 14 years. So I don't know if
Alright, time works and what I just told you, they had residents with the facility and with part of systems who will build the capacity of the healthcare workers and are good to go. We've done it. We did an initial training, we did refresher training again, another 4 days of refresher training, result to the baseline training. So the health workers are good to go in terms of digital literacy to continue to use the tablets. You asked a very good question, which is what I keep asking, and I'll get to that later. But I need to, at this junction, mention where the power of collaboration can really make a lot of difference. Now we say we have 4 months extension. How did we get 4 months extension? So when we came, we were supposed to engage 24 community volunteers and pay them. Then the police said, look, when you have volunteers in these places, why don't you train our volunteers and hire 12 more? So it is the cost savings from that 12 volunteers that we use to run the extension. So just go to the further than we don't play to, we use some of their volunteers. So we didn't have to pay 24, we just pay 12. So we have this savings. Can we please extend so we can reach more lives, touch man, also tie us so we can get additional funds to them to continue with them because we wrote down grants around this and 1 or 2 of them will fall through. Grant will be successful in 1 or 2 of them and we can continue and scale up. So that's where, and it was really helpful and we're really happy that we're able to collaborate on that level and make this savings. And they just happen for us to continue to use the savings to continue for the next 4 months. So we're hoping that within those 4 months, we are able to, first of all, address COVID. You notice and it's an ongoing thing, like we said. Every time we go for supervision, there's always something to tweak. You understand? Always something to tweak. Tweak this a bit, and that's when we got to where we are. But there are a lot of other things to tweak again around that. So yes, we will do back to a formal policy or policy report to the end as Kwara State Prime Development Agency, where we highlight everything in very clear terms and make our recommendations to the executive secretary and see where we can go from there. Of course, in the CVs, the 12 CVs body, if you don't get additional funds and we have to give our performance, then we'll still have the 12 CVs from the WHO are still working and they're training officers so they can continue using it. The only challenge will be now for the healthcare workers. In this CV, with some of the arguments around sustainability, when this DAs to do the manual entry, if those DAs go after the 4 months, then we need to do both manual entry and digital entry. We're looking at the whole different ballgame. It's a different problem for them because it means that we're actually doubling their work, which is what we're trying to do. Digitalization is supposed to make life easier, make them more efficient, make them more effective. What they're supposed to do on our things, they send them this meeting. And again, just to comment on what you said, we have testimony, and we actually have videos. They wanted to put it in the presentation. I said, nah. That's why they were looking at me. When you said it, I said, no, we don't need that. No, we need it for some other things. But we have testimonials from caregivers, from community volunteers, and from the healthcare workers, and work on video and the writing. So I told you to really have this presentation, but I think it was really that important. But now you said it, and I'm sorry, so I was wrong. And I'm sorry about that. So that's how far that goes. It's all work in progress again. A lot of things to be done. But we will get to that place of perfection, like we said, if we can get a unique identifier. That's the thing. That's one of the main issues. And I know it's a difficult task because it means that you have to change the entire, M&A structure for the immunization system. It means that you need to now start, but it is critical if you want to digitalize. It means you cannot have a set. Right now, like I said, we have compartmentalized. Each PhD have a comp. Once you bind them together, you start seeing duplication and it scatters the whole system. You understand? Because you have 001 in like 10 places, 002 in like 5 places. You understand? So it becomes a system that, when you have a unique identifier that goes to the community level, where you can now do your community record planning and all those activities that go around the community, it makes everything seamless. Then you can have a state database and a national database, just like we have for the HIV program. Every HIV patient has a unique identifier that is unique to them in the country because it goes from the from the state to the facility to the patient, you understand? That's how it is. The number it's a unique identifier that anywhere you go to Nigeria as an HIV patient, once they punch in your number, everything pops up because we're on the database, and that's how it should be with organization. So if we don't have that unique identifier, we can't have one database for everybody that can synchronize everything both at the state level and at the national level. So that's the first thing I need to be. It's a big as we look at it, it's going to require some commitment, but it's something that needs to be done if we want to address all of the challenges and then move forward. And like God said, digitalization is going to go addressing, our most of our problems. Again, I think we're ready for something to say. So we're starting, I think it was from UIT, the partner from UIT, sorry, I forgot you. Yeah. So we start from somewhere. In fact, we have a grant that we wrote that we are integrating back to ANC now. Because now we have some data from ANC, but we realize that if you want to capture the entire, that's how technology and innovation works. So you start organization, you can go backwards. You understand? Towards ANC, whatever the ANC interface, or going to just expand what is there. You understand? Include clinical, before we start working on it, include what are the things that's required for the ANC, so we can have a backward integration to this, so we can capture the entire ANC, so we can begin to track women, we can even predict. We can bring up things, tracking women from their pregnancy, and they are tracking their clinical history, are tracking all their records, including pregnancy history, so, and including their gravidational history, their para history. And that's what makes AI work. It is the richness of data. So it's called big data. The bigger your data, the more robust your data, the more magic you can do. And I call it magic, but really it's magic in terms of making a difference in what we all do. And then for integration, you cannot go, because we have the children's database, you cannot extend it beyond that. You can extend it when they are 5 years old, 10 years old, begin to integrate that data so you can have a longitudinal data that's from pregnancy up to when the child grows old. And it becomes something that anybody can build on. They can build any solution on it and will address all kinds of problems for the country. And that's where data becomes really rich. And the richness and the robustness of the data is what makes it all different. So you begin to introduce AI, machine learning, and all those algorithms and things like this. Again, to reach your question, when we first came in August, I think in July last year, but sometime June, we didn't have HPV in mind, but the GSI, I will never forget it, he told us that we need to include HPV. So yes, you have HPV at 9 years as part of the spectrum of immunization to take. So we have to include, because of that meeting we have, okay, we need to include it because it's that part of the national immunization program. So we included HPV on the schedule. So it means that you have to fulfill with the child to remind you when the child is 9 years. That's the picture of the question to meet it. When the child is 9 years, it will send a reminder that this child is due for HPV vaccination and we can take it from there. So I will stop at that, and I don't know if there are any other responses that anybody wants to give, and then we can take it from there. Thank you very much.
Let's now go this. So, thank you everyone. I want to thank everyone for the feedback. We are so grateful and we noted one of those points down. So, next on our agenda is the closing remarks. So to bring this meeting to close, I'll be calling on Dr. Ogunjoyi for the closing remarks.
Thank you very much. On behalf of the Deputy Secretary, I want to appreciate the role of Student Access Initiative
from rural area, and that rural is very far to the town. So this app is helping our community very well, because on getting to them, immediately they saw me typing their name of their children on the app. So they were very happy that my name is entering to the computer. In our area before, they usually reject immunization, but during the time of introduction of this tab, immediately they saw me with my tab, they allow me to come and vaccinate them. But they think that this tab, their name is entering here, their name is not staying in their community alone, their name is taken to Abuja. So thank God for the app. The app is helping us in our community.
My name is Wahid Data Associate of Equitable Health Access Initiative. working with Oketuna Primary Healthcare Center in Ilorin's local government. Since inception of the project, I discovered in my health center that the RI officer and the data RIANC officer are very happy in using the app, saying that it increased their coverage because formerly in Okelele Health Center.
Thank you, and to say that Kwara is grateful and we are willing to cooperate with you to ensure that this becomes a national project. God will. Amen. Still bring back to people will say, they will say, it is not bad, but see you.
Thank you so much, sir. Please clap. Thank you so much, sir, for that closing remarks. So to express our appreciation, please go on with me, Mr. Shehu Ali Dube, for the group of thanks.
Please come on. Our hand is once again acknowledge the Executive Secretary of the Primary Healthcare Board, precisely looking at Ilorin report, Professor Osrat Elebu, the Commissioner Absentia, the directors here present, most importantly, my very good friend, Dr. Michael. I also want to acknowledge the present, our wonderful partners here present, people of IDT for your commitment. I also acknowledge the presence of SIOs, LIOs, and of course, everybody here present in this August meeting. We are respectfully say here that my God here is very slow. Just say thank you. And I'm here to say thank you. Thank you. On behalf of the Dissemination Health Access Initiative, everybody led by our Chief Executive Officer, Dr. Timothy, and of course, Pfizer Foundation that have been able to power this project for a couple of months, precisely a year. And for the management team of GHIG8, we want to express our profound gratitude to the entire team of Kwara State. Permit me to say this to the Executive Secretary. I'm not surprised for the kind of zeal, passion, tenacity, commitment, collaboration, integrity that you have exhibited and the entire team have demonstrated in the course of this project. As of yesterday, you know, we met the day before yesterday. As of yesterday, I was in a function where His Excellency Governor Razak was there. And exactly what he demonstrated was what he did. We were so spontaneous, readily available at any given time. So in that function, people were saying he will come. They said he will come. So we saw him. The way he approached every one of us in the meeting was like, maybe he was already prepared for it. But I'm not surprised if the government had do that. The foot soldiers, the think tank, the pain behind the box, have also demonstrated that to me. So I was not surprised when the Executive Secretary Bob said that can we have the meeting today so that I will be ready, available, and also show my commitment. Thank you so much for your passion for your commitment. We salute your integrity and your support for the success of this program. And of course, I also want to appreciate, it's my mom, it's my brother, but I need to say it here openly. From the commencement, inception of this program to date, he has demonstrated 101% commitment. Dr. Michael, I appreciate you so much. You have nothing to say than to say thank you. So all the directors here present, we appreciate your synergy. Nobody is even trying to pass the pop on one, but everybody works together as a team.
My UNICEF, our partners, WHO, Affinites, Chigari, every one of us, in fact, to some extent, during the training, during one of those sections, I was privileged to be part of the meeting. And interestingly, the way the meeting was done was as if it is their baby. So we appreciate you, we appreciate the collaboration, we appreciate the support, and we also appreciate the kind of synergy you have created, even among us in the partner. During the entry, we remember what you did for us to have leverage for each and every agencies. Thank you so much. The representative from UITH, you are not left behind. We appreciate you for what you have done. We appreciate everything that has been done. UITH is a family house, even to our CEO. So we are ready to continue our support at all levels. Once again, on behalf of the management of EHI, I would want to say this to close it. The SIs, O's, LIOs, you are not left behind. Your efforts for us to be able to synchronize the system was behind you. You were able to have a kind of synchronization in the system. And as we have said, with the Secretary of Office said, we have taken the feedback and we are also ready to integrate all inputs to ensure smooth running of the operation. We are not leaving. Technically, we are here together. And I'll close with this. When you are hosting a hall for a blind man, you should continue to whistle. Because if you don't continue to whistle for the blind man, the perception of the blind man is you are eating what? You are eating the corn. Kwara State continue to blow the whistle, continue to ensure continued health system friendly, and we as partners, we are also ready available to support you. Thank you so much.
Thank you, sir. So we've now come to the end of today's meeting. Thank you, everyone. I'll be calling on the gentleman for the closing prayer.
Good afternoon, sir. Thank you to recognize our CS, the Secretary Kwara State Primary Development Agency, the person of Professor Mosra, and then we are also recognized. And it means to also recognize our able director, Dr. Michael Umuntoye, our big partners, the WHO Cabinet, all other officers. So on behalf of my HOD, I'm standing for the HOD who went for another national assignment. So on behalf of the Ilorin East local government, we are very grateful for this GHIG8 initiative, because this program is a big program and a lot of money is invested in it. So as the ES has rightly said, we want the sustainability of this project to because this. I want to thank the others people. So we pray that Almighty Allah continue to guide you directly to the right path, and at the end of this project, we have cause to give glory to Almighty Allah in our time.